Today is the Heart Failure Symposium, and we have some excellent talks which are going to follow. Dr. Ripen Gupta, who has already been introduced to you by Dr. Chauhan, is the Director Cardiology at Max, and he will be speaking on the burden of heart failure and following it up with a talk on the quality of life. Vis-a-vis heart failure, we often tend to forget that it's not only the endpoint of treatment of heart failure, but how the patient is doing over the years, whether how much he is able to contribute to society, how much he is able to be interactive with his family, and these are things which are extremely important because often end-stage heart failure cases do land up with status of depression and a feeling of that can't do anything else, and especially in the light of increased longevity of life, these things have become all the more common. So it's my pleasure to introduce Dr. Ripen Gupta and ask him to deliver his talks in sequence. Thank you.
I thank Dr. Chauhan for giving me this opportunity to give this talk at this forum. I think I am not new to this. I have given talks before also. So basically I will be talking on heart failure. I think the topic I am discussing today is nothing new. It is an old topic. We all know that heart failure is a very major problem. In fact, if you take cardiology, this is one of the major bugbears because we can put a stent if there is a blockage. If the patient comes to us with an ACS, we can treat him well. But if his myocardium gets damaged and he is in heart failure, I think that is a time when we also have very limited options. Despite the advancement in medical therapy, we know that mortality with heart failure is still very high. So this is a lingering problem. The heart transplant program, the artificial heart program, all are driven by heart failure. And I think this is the one last frontier in cardiology which needs to be conquered. If we can improve the heart function of a patient, we can increase the longevity of that patient. So that is very, very important aspect, heart failure. And if you look at the burden, I will not bore you with the details of slides, but it is a major health problem. Millions of patients are affected by this problem, and it causes something like more than $100 billion loss to society every year. The average mortality with the heart failure patient is 50% at 5 years. Means if you have a heart failure, around half the patients are going to die before they reach the age of 50 years. So that is very 4 or 5 years have passed in, and this is worse than a lot of cancers which we see, because a lot of times we think that heart failure is a benign condition. Patient had breathlessness, he got admitted in a hospital, he got stabilized, now he's going to live longer. But if we take 100 heart failure patients and follow them for the next 5 years, half of them will not survive despite the best medical therapy. So that is the magnitude of problem, and this is worse than a lot of cancers. In fact, prostatic cancer, even breast cancer has better prognosis than heart failure. So this thing should be remembered by all of us, that heart failure is a big issue. And now we define heart failure into various categories. So this also should be remembered by us. I am just recapitulating all things. One is heart failure with reduced ejection fraction when the patient has a LV ejection fraction less than 40%. Then it is a mid-range, which is 40 to 49, and then more than 50 is a preserved ejection fraction. So these three subgroups are also important, and we have to know the setting of the heart failure. It is acute heart failure or a chronic heart failure. Then we have to know whether it is a new onset heart failure or it was a patient who had a problem for a long time. And then involvement of the heart, whether it is predominantly affecting the left ventricle, right ventricle, or combined. So these various definitions are there, but very important is the definition which is based on LV ejection fraction. So if the LV ejection fraction is less than 40%, it is known as heart failure with reduced ejection fraction, and that will be the basis of our topic when I give the next presentation. And then we have heart failure with preserved ejection fraction when the EF is okay. and both are equally important. I'll come to that in the next few slides. And this is the etiology of heart failure. The most common factor is myocardial infarction, that is coronary artery disease. But there are other factors also, like congenital factors. Then we have a lot of valvular heart diseases which can lead to heart failure. Arrhythmias can also lead to heart failure. So there are multiple factorial factors which can lead to heart failure. I will not discuss all the slides, but you can see that there are around 20-25 causes which can lead to heart failure. But if you take majority, 70 to 80% will be driven by coronary artery disease and diabetes. So these two will lead to majority of the heart failure which we see in our clinical practice. And unfortunately, the incidence of myocardial infarction is decreasing, but the prevalence of heart failure is increasing, especially in the Western world. If you take India, the incidence of coronary artery disease is also rising and heart failure is also rising. But if you take US, and this is data from US for the last around 35 years, you can see the prevalence of heart failure has gone up, and the similar slide will show that prevalence of coronary artery disease has gone down. The reason is that with passage of time, the diabetes has become more prevalent, and that is also driving a lot of heart failure patients. If you take heart failure, for preserved ejection fraction, again same data is there, it is increasing, and now there is a lot of confusion. Once we do an echo in a patient and we see that the LV function is normal, and even if the patient is breathless, we feel that this patient is going to do well because his EF is okay. But if you have a heart failure with preserved ejection fraction, the hospitalization rates are similar as compared to heart failure with reduced ejection fraction. Means HFrEF and HFrEF both are carrying similar prognosis, similar hospital readmission rates. And if we see the length of stay, that also is similar with both, and it has increased over a period of time because we are now having more complex heart failure cases. Mortality is same if you take heart failure with preserved ejection fraction or reduced ejection fraction, and heart failure survival rates are not improving. Again, this is data more for preserved ejection fraction. If you look on the left side of the screen, you will see that the heart failure over the years, this is 98, we have divided into 3 decades. In preserved ejection fraction, there is hardly any difference. But if you see the reduced ejection fraction, we can see that with the passage of time, the heart failure mortality has reduced somewhat, and that is, I think, because newer agents have come in for reduced ejection fraction, and they are driving the reduction in mortality in this subgroup of patients. So what we can see in nutshell is that heart failure is increasing in prevalence over the years. And heart failure with preserved ejection fraction and reduced ejection fraction has similar initial hospitalization rates and similar re-hospitalization rates. Mean length of hospital stay has increased because complexity of patients have become more, and both carry same mortality, and the mortality has not changed for preserved ejection fraction. We have still to conquer the preserved ejection fraction because we have very little data or molecules for that. But for reduced ejection fraction, we have RNA and other beta blockers which are now leading to reduction in mortality. So this was just a brief presentation on epidemiology. Now I come to the main topic of today's discussion, that is quality of life indicators in heart failure. So whenever we discuss heart failure, we always talk of mortality. But for a patient, mortality is not important. Let's say you tell me that I have a heart failure and you are going to die in 5 years. But these 5 years, how I am going to live those 5 years are very important. If I am going to be not able to do my routine work, I am breathless if I go to toilet, and if I am not able to carry out my activities, I am feeling lethargic all the time, then those 5 years are useless for me. So very, very important aspect is that we should have a good quality of life for our patients of heart failure, and we should know which molecules are there which are helping us in getting a better quality of life for our patients. Second, what we should also understand is that does quality of life only means the patient's well-being, or it gives us some further information also. So we'll see in the next few slides that quality of life is also linked to the mortality of the patient, is linked to the hospitalization of the patient. So those all factors are important. So why improving quality of life in heart failure patients should be one of the key management objectives. So that is the first question, and let's so what we know that a patient who is having heart failure will be having, as Dr. Sengupta was mentioning, he will be having breathless, he will be having palpitation, he will be feeling dizziness on walking, but at the same time he will be having some other issues also. He may be having anxiety because of his problem, he may go into depression, he may have sleep disturbances. So this all will impact his quality of life. Can he do his routine household work? Can he go to his job? Can he carry on routine activities? These are all very, very important, and they have been quantified by various scores. So when we talk of quality of life scores, the scores are like, if the score is higher, it means the patient is better. If the score is lower, it means the patient is not doing well on the score. So when I show the few slides on quality of life measurements, the scores are dependent on that. So number one, if you take the heart failure patients, it is seen that if there are patients, let's say 100 patients, at the end of 1 year, there will be a deterioration of heart failure score of more than 5% in around 33% of the patients. So as the patient of heart failure progresses, his quality of life becomes worse. So that is one thing which we should remember. One third will have a worsening of their indicators. And if we see the quality of life, now this is a very interesting slide. It shows that as the time goes by, mortality is inversely proportional to the quality of life scores. So if the score is higher, mortality is relatively lower because the patient has a better quality of life. If the score is lower, that means the patient has a worse quality of life. He will have more chances of having mortality. So clearly, quality of life does not only mean patient well-being, it also tells us how is the patient going to behave, how many of these patients will die in the next few years. So if the quality of life is not good, that indirectly means that patient is not going to do well in the next couple of years. So again, we know that if the quality of life is not good, that 1.5 times more chances of death and heart failure hospitalization are there if the patient score decreases by 5 points. So that is very important. And similarly, the mortality rate depends on the NHA class also, but it also depends on the quality of life. If the patient is NHA class 1 and 2, but his quality of life index has gone down, that means asymptomatic patients but quality of life is not good, their mortality increases by 1.7 times. So that is very important that even a patient who is having minimal symptoms of heart failure, but his quality of life is not good, his mortality is higher as compared to a normal person. So one thing is very clear, that poor quality of life in patients with heart failure is linked to negative clinical outcome. So that is very important, we should remember. So besides improving the mortality of the patient, if we can improve the quality of life of the patient, it leads to better management of heart failure. So what are the recent guideline recommendations of management of these patients? So out of, if you take the recent guidelines, European Society of Guidelines 2021, they have put ACE inhibitors, RNA, beta blockers and MRA as the three important steps in the treatment of heart failure. Along with that, we can add SLC2 inhibitors also because a lot of data has come in. And out of which RNA is clearly to be preferred over ACE inhibitors. And this is reiterated by both the European Society of Cardiology guidelines and by the ACC 2021 guidelines that we should prefer RNA over ACE inhibitors. And now we have a direct RNA approach. That means if a patient comes to me, I will not start him on ACE inhibitor first and then switch to RNA. I will straightaway start him on RNA. Even if the patient comes to me as a acute decompensated heart failure and he is admitted in the hospital, I will not give ACE inhibitor first. I will give RNA straightaway. Only thing to remember is that the patient is already on ACE inhibitor and you want to switch to RNA, you have to give a gap of at least 48 to 72 hours before you can give. So there has to be a drug-free interval of at least 2 to 2.5 days between the two molecules, because if you give ACE inhibitor and RNA together, sometimes patient can have angioedema. So that is a complication which can happen. So we have to just remember that thing. If you are in doubt that patient, whether the patient has taken Ramipril or not, then give a gap of 2 days and then you start RNA. Don't give them together. So if you look at the various therapies, beta blockers, ACE, ARNI, do they impact the quality of life? Because we know they improve mortality. In fact, the highest mortality reduction is seen with beta blockers. But problem is that beta blockers do not improve quality of life. So that is very important to remember, because you give a beta blocker and you say, oh, I've given a medicine which will lead to 34% reduction in your mortality. So patient says, doctor साहब मुझे तो अभी भी सांस फूल रहा है, मैं तो 4 कदम चल नहीं पाता. So what is the benefit? So clearly we have to give a molecule which makes the patient feel better also, and which improves the quality of life plus the mortality. If we take ACRPs also, they have some improvement in quality of life, but they are again not the best molecules. What has been seen that ARNI has a very significant impact on quality of life. And this I can vouch from my clinical practice, because when I started giving ARNI, I gave them because of the mortality benefit they have over ACE inhibitors. But once you start an ARNI, and ARNI is a very expensive molecule, 95% of my patients never say stop ARNI. They will say, doctor, isko medicine ko mat band kariyega, we are feeling much better. I tell them that, okay, this is a costly medicine, and if you cannot afford, then we may have to switch again to ACE inhibitors. They say, isko nahi band karna, ye main kaise le lunga. So clearly this tells me that this molecule is better. Now let's see what is the evidence. This is experience, my own experience, what my patients are telling me, but what is the role of ARNI in quality of improving the quality of life? So number one is the various scores which we have, like cancer's cardiomyopathy score. That is the one thing which will quantify the improvement. Yeah. Then we have various activities which patient does, various domestic activities which patient can do better after patient has been started on ARNI. Then we have certain objective methods also. We can look at the peak VO2, 6-minute walk test, the respiratory efficiency which can be done in a hospital setting. So all these tests will tell us whether our theory is okay or not. And we can clearly see that various activities, day-to-day activities, there is a substantial improvement in 8 months once we have started a patient on ARNI. So that means clinically patient is feeling much better. And the scores show that the improvement starts within 2 weeks. So that is the beauty. You can see that once we start ARNI, the clinical score starts improving within 2 weeks, and then this benefit is maintained over the period of time. And if you compare ACE inhibitors with ARNI, there is a 5-point more improvement in quality of life index as compared to ARNI. ACE inhibitors. So ARNI is better than ACE in quality of life also, besides mortality reduction. And again, this is again shown in this slide that if you give ARNI over ACE inhibitor, there is a better improvement in quality of life. And overall, the difference in aging, there is a concept of aging of the patient. So there is a 9 years difference in aging of a patient if he is given ARNI as compared to other molecules like ACE inhibitors. So clearly, ARNI improves the patient's well-being. ARNI will lead to a better reduction in symptoms, hospitalization for heart failure, and also it will improve the longevity of the patient. And if you look at the parameters, this is called paradigm HF study, there is a 20% reduction over and above ACE inhibitors in clinical parameters. CV death is reduced by 20%, heart failure hospitalization is reduced by 21%. So clearly, there is no doubt that ARNI is a better molecule as of now. That is not no doubt, but the quality of life indicators which are there are also very, very important, and that also is favorably affected by ARNI. So that gives us additional reason to prescribe this molecule. And here we are comparing various groups. Let's say we give a patient a ARNI, a beta blocker, and MRA. Another group we give ACE inhibitor, beta blocker plus MRA. And you can clearly see that the maximum benefit is seen when the patient is receiving all the three. The patient is receiving an ARNI, he is receiving a beta blocker, he is receiving a mineral receptor antagonist MRA, and there is a 62% reduction in all-cause mortality which is seen. And if we look at the hospitalization for heart failure, again this combination leads to a 42% reduction in hospitalization for heart failure. So clearly this is the preferred combination as of now, where we should try to give all the three agents to the patient. This is a very interesting slide, and most of us may not be aware, but in an echocardiographic sub-study, it was seen that there is a 12.8% improvement in LV ejection fraction when you give RNA. So a lot of my patients where I have written, you need a combo device, you need a AICD because the E was 20-25%, I have removed them from that list. And few patients where we were contemplating heart transplant, we have moved them from the list once the patient was an RNA. So that is very, very important. 12.8% improvement in LVF is very high number. So even a 3 or 4% improvement in LVF will be considered highly significant, but we are talking of something like 12.8%. And this is seen in heart volumes also. LV and diastolic volume index, LV and systolic volume index also decrease. So it means that what happens is that the heart size decreases once you are giving them RNA. The heart comes to the natural shape, the ejection fraction improves, and that clearly drives the clinical benefit we are seeing. So, to summarize, and this is my last slide, improving patients' quality of life will be considered as an important aspect while managing heart failure for reduced ejection fraction. We should go with the guidelines, time is essential, and we should initiate RNA as our first line drug in these subgroup of patients. Thank you.
Very good.
Thank you, Dr. Ripen, for such a wonderful elucidation of heart failure and this impact on the quality of life. Very heartening to see almost a 13% improvement in the LVA. Do we have Dr. Gagan Chhabra here? Yeah. So may I invite Dr. Gagan? I think he will be speaking next.
Question.
I think I can answer a few questions in the meanwhile because it may take some time to download the slides.
So then should I go ahead with my talk?
I think better will be to go ahead with your talk. Because I think I have to download the slide. It will take a couple of minutes.
I think I'll have my talk and then. How much time will it? Dr. Gagan Chhabra, the senior consultant nephrologist at the Max Super Specialty Hospital. He will be delivering a talk with respect to the status of renal function and especially the involvement of the RAAS in the context of heart failure. Dr. Gagan Chhabra.
Thanks for the introduction, sir. It's a pleasure being here, and thanks to the Society, the Physician Forum, as well as the Novartis for giving me this opportunity. I am Dr. Gagan. I am a nephrologist at Max Sarthe. So, going with the topic given to me, heart failure and changes in kidney function, role of RAAS inhibition. Now, understanding, not react. I will not say not reacting, it's a cautious reaction which is required. So, just an overview. Now the question, how many heart failure patients with renal dysfunction do you see in your clinical practice? If you ask me, my answer will fit somewhere in around greater than 80% patients, because me being a nephrologist, everybody is going to have renal dysfunction. So probably a patient coming with heart failure fits into more than 80% of the patients which are coming if there is a heart failure issue. But in case of a cardiologist, I would say 50 to 60% of the heart failure patients present with values of eGFR less than 60. That means CKD stage 3. So around 50% of the patients of heart failure have CKD stage 3. Now 20 to 30% incidence of AKI during the treatment for heart failure. This is also interesting. So while you treat the heart failure, you see that the renal function gets deteriorated. So it's to the tune of 20 to 30%. Incidence of de novo heart failure in non-CKD patients is around 17 to 21%. And 44% of the patients with end-stage renal disease have heart failure. So you can imagine, end-stage renal disease means the patients on dialysis, and we have approximately 44% of the population who have heart failure. So this is a big number here. So moving further, this triangle also shows the same thing. The more the AKI is, the more is the mortality. I'm not going to the colors. Now this is interesting. So as we know, it's a bidirectional interaction between heart and the kidney. So you see, the nexus starts with the cardinal syndrome here. So it is this cardinal connector. So what are the connectors? The trigger may origin here in the kidney, or the trigger may come from here. So this trigger means a cardiac dysfunction, which may be due to any of the cardiac ailments. this trigger is a renal dysfunction. Now this renal dysfunction may be due to primary glomerular disease, renal artery stenosis, or any other renal ailment. Now there are certain systemic diseases which can have this trigger also and this trigger also. So these include like cirrhosis, vasculitis, sepsis, and other systemic involvements. Now either way the trigger comes, these are the connectors. What are the connectors then? The connection lies with the RAAS activation, which is the main problem here. Oxidative stress, which is another is a problem. Inflammation. Now inflammation is problem everywhere now. This is the current problem, which is a connector, and then comes the sympathetic nervous system activation, which is another problem. So these are all connecting and leading to these connectors. Now what we have to do is to treat these connectors to get a better outcome. These are the consequences of this kidney dysfunction, anemia, metabolic abnormalities, and volume overload. We all know about it. Now this is a complex slide, I will not go into it. I will just tell you in brief that in chronic heart failure patients, a progressive loss of renal function occurs over time. This is the same thing. You see these are the common factors which are listed here, both for the heart and the kidney that are causing the problems. And then these are the markers of the kidney disease as well as the heart disease. The markers include albuminuria, that's a kidney marker, enzymes, that's a cardiac marker, NT-proBNP, that is a cardiac marker but works well with kidneys also, and the other kidney markers like NGAP. So these are the markers which play a role. So the markers also tell us what type of function or dysfunction we are having. So this is the nexus again between the heart and the kidney. Moving further to the next slide. Now, pathophysiology of changes in renal function in relation to the timing of hospitalization in the acute heart failure patients. Now, as the heart failure patient gets hospitalized, we know there is a renal dysfunction that starts precipitating. Now, what is the reason for that renal dysfunction and what is the reason for the precipitation of that function? So, it's acute heart failure that leads to decreased renal blood flow per se, or due to a venous congestion leading to a decreased renal blood flow. Decreased cardiac output also plays a role. So all of this together is leading to a reduced renal blood flow, venous congestion, and ultimately the worsening of the renal functions. Now this worsening of renal functions also is occurring because of late during hospitalization. Now late during hospitalization means that we are in the hospital for a longer duration of time, and now the kidney function or dysfunction, I should say, starts setting in. Now why does it set in? Either it's a pseudo kidney dysfunction. Pseudo means that it has been created by diuretics. We have given excessive diuretics, the patient gets dehydrated, the renal dysfunction precipitates. It's a pseudo renal dysfunction. Created by RAAS inhibition. We increase the RAAS dose thinking that the heart failure will improve. It leads to renal dysfunction, it's a created renal dysfunction. Now, some renal dysfunction is a true renal dysfunction. That will improve, that may include infections, sepsis, or other ailments that causes the AKI like toxins, contrast, which we all use in the cardiac patients. So that's the difference between late during hospitalization and early during hospitalization. Now moving further, if RAAS inhibition is so good, it's a cornerstone of therapy for managing both chronic and hospitalized low ejection fraction patients in one of the major factors which can lead to renal dysfunction. Generally leads to withdrawal of stopper of RAAS. So what is the knee-jerk reaction is, anybody in which an artificial renal dysfunction has been created or a pseudo renal dysfunction has been created, you immediately start withdrawing the RAAS. Is it correct or is it bad? Let's see. So, but it is beneficial to stop RAAS in chronic and hospitalized patients with renal dysfunction. The answer lies in the forthcoming slides. Yeah. So this slide also shows renal dysfunction, unwarranted barrier in heart failure therapy, leading to decreased survival, increased hospitalization, and disease progression. So the cause of worsening renal function during a decompensation episode needs careful thought regarding the volume status of the patient and whether the RAAS inhibition are the prognostic benefit. Now, this slide is very interesting. Gosh, this is continuation of the RAAS inhibition leads to longer life expectancy and delaying the worsening patients in low ejection fraction patients. Now, the first thing coming into our mind is we should not do any harm. So that means withdraw the RAAS. So actually, by trying to not do any harm, are we creating a harm? The answer lies with this registry which reported 1 year mortality of 28.2% in patients with continued the RAAS therapy, RAAS inhibition therapy, but 41.6% of the patients who had discontinued this therapy over the next 2 years. So discontinuation of therapy has actually increased the mortality. Similarly, if you add on the RAAS, the mortality is decreased to around 29.7%. But if you do not give RAAS, never use it, the mortality is as high as 41.7%. So that shows the importance of this molecule. Now this is very interesting. This is a samsara of the stopping RAAS. What happens? It's like a chapter in which the organ got trapped. Heart failure with the worsening of renal functions and hyperkalemia. What we do? We stop the RAAS. Now here we stop the RAAS. What happens is the creatinine starts coming down and we are very happy that we actually saved the patient. What happens is that clinically the patient starts deteriorating and then eventually the outcome is bad. And then we are in a loop and we are never able to restart the RAAS, and patient eventually goes into renal failure and needs to dialysis. Now what happens if you try and continue with RAAS but with caution? The word is with caution. So continue RAAS inhibition. The creatinine and the potassium may increase but we are very cautious. We are monitoring it regularly. Next step comes, patient improves clinically. That leads to a better outcome and exit of this negative loop. So here it goes out and patient gets discharged. So this was very interesting. Management of RAAS inhibition based on changes in the renal function in low ejection fraction heart failure patients. So what is the requirement is the clinical assessment. That is the key. So compare with the baseline renal function. We should know what is the baseline renal function before the start of the therapy. What is the actual renal function of the patient. So that we can know the increased value. And how much is the increase? Assess fluid status of the patient. I am not going to detail, everybody knows about how to assess the fluid status. Interpret the BP in conjunction with other things. That the fall in blood pressure, is it important? Do we need to actually stop the RAAS? And what is the reason for blood pressure fall? Is it diuretics? Do we need to give fluids? That needs to be assessed. Then comes withdrawal of RAAS in symptomatic hypotension. Yes, if the hypotension is symptomatic, we should withdraw RAAS inhibition. Repeated clinical and biochemical assessment is vital. So we test again and again to see whether it's deteriorating or not. Presence of moderate or severe hyperkalemia may override the recommendation. So potassium becomes important. If somebody is having a renal dysfunction, creatinine not increasing, but potassium is jumping up, you are not going to continue RAAS and wait for the potassium to cause the uremia. So that is also important. And in severe renal dysfunction, assess for the symptoms of uremia. So that these are the important points which need to be highlighted. Now this thing is again very interesting. Change in the renal function compared with baseline. If the change is to the tune of less than 30%, continue unless symptomatic hypotension. So if the creatinine jump is less than 30%, we continue until unless there is a symptomatic problem going on. If the increase in creatinine to 30 to 50%, we consider reducing the dose. If the increase is to the more than 50%, we temporarily stop the RAAS. And in the severe renal infection occurs, naturally with the GFR less than 20, we are not going to use RAAS. So this is very clear here. Now this is again a very interesting study. Now what happened in the study? This is a follow-up study in which the patients were given, around 10,000 patients were studied and RAAS inhibition was used even at a GFR of less than 30. So what they found was, in spite of the fact that continuation of RAAS leads to more renal replacement therapies, more patients going to dialysis, but it actually improved the mortality from 54 to 40% and also the MACE events from 59 to 47%. So the cardiac events reduced and the mortality reduced. But with the compromise that the patients were, some of the patients went to the renal dysfunction and the starting of the renal replacement therapy. Now should we continue with RAAS inhibition despite complications? The answer is RAAS blockers are not nephrotoxic drugs, they only have a functional effect on renal function, so we may consider continuing them. Now this is another interesting molecule. This is RNA. RNA is inhibition of the neutralizing and as well as the ARBs. So why we require a combination is because of the fact that neutralizing inhibition leads to a more active natriuretic peptides. The more active natriuretic peptide is good for both heart as well as the kidneys. So we need more of a natriuresis. To create that natriuresis, we need to inhibit the natriuresis. Now inhibiting the natriuresis also leads to more angiotensin 2 as well as bradykinin. So if we do not inhibit angiotensin 2, if we only inhibit natriuresis, that's going to be a problem. So we need an ARB along with that. That's why the combination is very important. So what does the combination do? The combination inhibits natriuresis as well as RAAS, leading to vasodilatation, natriuresis and diuresis, which we all want. Also leading to lesser vasoconstriction, lesser sodium retention and decreased fluid retention, which we all want. So it's a win-win situation in case the patient tolerates this molecule. So this is a study which shows superior impact of the RAAS inhibition in heart failure in CKD patients, 30% lower risk of renal function with this molecule in RNA in comparison with the plain RAAS inhibitors being used. So again, RNA delayed the progression of decline in EGFR versus a plain ACE or ARB in low ejection fraction patients. Result from systemic review and meta-analysis. This analysis also showed that RNA delayed the progression of decline in EGFR levels by 2.4 ml per minute as compared to a plain ACE or ARB when used in a patient of low ejection heart failure. Similarly, 11% reduction in the risk of vascular failure with RNA as compared to a plain ACE ARBs. This also showed an interesting thing. We thought that ACE ARBs cause hyperkalemia, but it was shown in some studies. 3 out of these 4 studies have shown that hyperkalemia is less when RNA is used as compared to when plain ACE ARB is used. So these advantages appear to be there with both chronic patients who are the OPD patients as well as those which are hospitalized. So no need to stop the molecule once the patient is hospitalized. The advantage still goes on. Now, this molecule also is now this is very interesting. I am not going to go and try with this. This is only a few studies which have been used in CKD stage 4 and 5. I am not recommending their use in CKD stage 4 and 5. This is just to show that there was a 28% reduction in the cardiovascular death of heart failure operations with this RNA in real world settings in patients with a CKD stage 4 and 5. Now we do not recommend its use in 4 and 5. This is just a study. Now this is a similar study in which they are trying to use this molecule in patients on dialysis. This is also very interesting. The results are going to be out soon. Now this is a recommendation by the European Society, Cardiology Society. These are the class 1 indications: ACE/ARB, RNA, beta blockers, MRAs, SGLT2 inhibitors, and loop diuretics for patients with low ejection fraction. I think there is some problem. Still lights are there. Sorry, this is the slide we were on. Let's do it like this only, sir. No problem. Let's do it like this. So this is the slide which again shows the recommendation in which you see class 1A recommendation and of all these molecules and class 1B recommendation for RNA. Now moving further, ACC, that's American Cardiology Guidelines, recommend that RNA can now be used as a first line instead of ACE directly. But Europeans still stick with the fact that you try ACE or ARB or RNA, whatever you feel like is more comfortable with. Now those recommendations, these are the last 2 slides I am going through. Now in patients with it's okay. Okay, sir. Thank you. In patients with worsening failure and hyperkalemia, if urea and creatinine or potassium does rise extensively, consider stopping concomitant nephrotoxic drugs and other potassium supplement or retaining agents. So first step will be to stop all possible nephrotoxic drugs. Second will be, if no signs of congestion, reduce the dose of diuretics. Third will be, if rise in creatinine or potassium persists despite adjustments of the other things, try and reduce the dose of RNA to half the dose and wait for 1 to 2 weeks and see the effect. Fourth, if it is still high, the potassium is still greater than 5.5 and patient has a CKD GFR getting less than 30, that is stage 4, you stop RNA. Check the blood chemistry almost regularly so that we can monitor the potassium and the creatinine levels. The last slide recommends to evaluate kidney dysfunction. To better understand the underlying cardiac and renal physiology, we should keep a regular track on the kidney function of these patients with heart failure. To improve initiation, adaptation or continuation of evidence-based heart failure therapies, to stratify patients at risk of the adverse events, and to identify the presence of systemic diseases or other persistent or independent renal diseases, we should regularly monitor the renal function of these patients.
Very good.
Thank you, sir.
So thank you very much. Thank you very much, Dr. Gagan, for a very wonderful overview of heart failure with respect to the renal function. I'm a little more comfortable speaking like this, so please bear with me. So my brief in the last talk is with respect to heart failure, especially in the context of diabetes and prevention of hospitalization of heart failure. So diabetes, we know, is a condition which causes complications practically everywhere, and if uncontrolled leads to all kinds of problems. And it's not just a bystander, but rather an unwanted path which leads to heart failure. If you look at the basic pathophysiology, we get the triumvirate of hyperglycemia, insulin resistance and hyperinsulinemia, which sets up a cascade of multiple pathways of inflammation, dyslipidemia, endothelial dysfunction, cardiomyocyte hypertrophy LVH. The RAAS activation compounds that. You have increased calcium handling, increased fatty acid utilization with formation of advanced glycation end products. Also, it leads to autonomic dysfunction. The problem is that all these things leads to cardiomyocyte hypertrophy with LVH and precipitating in a status of heart failure and diabetes. Also independently, the level of inflammation, dyslipidemia and endothelial dysfunction ultimately culminates into a status of ischemic cardiomyopathy, again causing heart failure. Diabetes is an independent risk factor for heart failure, we know that, and it's a major risk factor for cardiovascular disease occurring in about 25% of heart failure patients. The prevalence of diabetes is higher, more than 40% in hospitalized patients for heart failure, and almost 3.5 times increase in the risk of incident heart failure due to the presence of diabetes. Worryingly, it is more common in women. So the coexistence has a very strong impact on clinical management and prognosis. For reasons of brevity of time and for the molecule in consideration, we will be concentrating on heart failure with reduced ejection fraction. And we see that it's an independent predictor of fatal and non-fatal clinical outcomes in patients with type 2 diabetes. Also, diabetes in itself causes the worst clinical status and increases the all-cause and cardiovascular mortality in the heart failure patients with reduced ejection fraction, and it represents a frequent comorbid condition in patients with heart failure with prevalence ranging between 15 to 50%. We all know this, and we know that in our clinical practice, once we are accosted with the patient with the conundrum of all these conditions, the morbidity automatically worsens. So if you see in this particular bar chart, the condition of diabetes increases the admission rates in heart failure patients over time. This has reflected statistics till 2015. So ostensibly, as we consider present 2022, the fraction would be much more, and it increases the risk of admission of heart failure by almost 5-fold. And frequent hospitalization leads to an increase in the mortality risk. So 30-40% patients are readmitted within 6 months post-discharge, causing a huge stress on the family, both in economic and practical burden. Hospitalized patients with heart failure have a high event rate, more than 50%, and some of them have been alluded to by Dr. Ripen Gupta and Dr. Gagan very beautifully. And unfortunately, with the mortality rate between 10 and 15%, 50% of the patients that diagnosed with heart failure die within 5 years after first hospitalization. So basically, you have a situation which is bad, and unfortunately till now there was not very much to do. And also at the same time, one has to recognize that it has been kind of under-recognized in terms of development of therapy over the years. It's only now that you have something better and concrete which you can offer to the patient. And hospitalization marks a fundamental stage to prevent further risk. If you see, it causes a status of neurohormonal activation and inflammatory activation with volume overload causing venous congestion, pressure overload causing pulmonary congestion, results in heart damage, the hepatocardiac syndrome or the cardiorenal syndrome, causing symptoms of peripheral edema, rehospitalization is there.
dyspnea, pulmonary edema, eventually leading to mortality. So preventing heart failure rehospitalization is key to improvement of patient outcomes and curb healthcare costs by identifying the high-risk patients. So what treatment options do we have? It's slightly busy slide, but suffice it to say that diabetes, you see all the pathways which culminate out here, and these are the treatment options that we have. Leads to myocardial infarction or ischemia, causing both the syndromes of heart failure with reduced or preserved ejection fraction, leading to heart failure, and which causes, a progressive LV dysfunction with neurohormonal activation of the sympathetic nervous system and the, increased activation of the RAAS. These are the medicines which are there on hand to help and try and ameliorate the condition. So treatment challenges in heart failure patients with diabetes. The problem is that severe heart failure, several heart failure therapies like beta blockers and diuretics might aggravate dysglycemia, and also they basically cause symptomatic improvement, and as already been mentioned by Dr. Ripen, they do not increase the quality of life per se. A therapy that is protective against incident diabetes or worsening glycemic control will always be a welcome addition. So what are the treatment alternatives that you can have? You're looking at the ASARBs, ARNIs, SGLT2 inhibitors, the newest kids on the block. ASARBs with combination with SGLT2 or ARNI in combination with SGLT2. So let's see what the evidence suggests. The recent ACC 2021 consensus recommends sacubitril valsartan as a first-line therapy for all heart failure patients with reduced ejection fraction. This is standard now, accepted worldwide. And the consensus 2021 says that this combination is the preferred renin-angiotensin inhibitor over ASARBs for all such patients, and direct-to-ARNI approach is now recommended. It shows superior benefits over ASARBs in heart failure patients and has an expanded role focused on optimizing heart failure for therapy for heart failure, superior benefits in de novo patients, and rapid improvement in patient-reported outcome measures, all in terms of symptoms, physical functioning, very importantly the quality of life. And cardiac reverse modeling effect has been seen independent of the background therapy with ASARBs. It shows beneficial effects in heart failure patients with diabetes. The angiotensin receptor blockade causes increase in insulin sensitivity. There is decrease of endothelial dysfunction. There is, amelioration of oxidative stress. The flow-mediated vasodilation becomes better, and also the cardiac remodeling is helped. And neprilysin inhibition has already been discussed with by Dr. Gagan. It increases the natriuretic peptide levels, causing increase in the insulin sensitivity, increased lipid mobilization, increased insulin metabolism, increased adiponectin release, decreases blood glucose levels, postprandial lipid oxidation is increased, and muscular oxidative capacity. So pretty much all the good things that you would expect from a molecule to be doing in such a situation. Increase in bradykinin, which increases the insulin sensitivity. Increases GLP, very importantly, obviously having anti-hypoglycemic effects. Increase in the skeletal muscle CGMP status with facilitated lipolysis and vasodilation, and decrease of the DPP4 activity, again which causes an improvement in beta cell function. So it improves the insulin sensitivity, lipid mobilization and oxidation by augmenting the natriuretic peptides. And if you see in this particular graph, if we consider heart failure hospitalization and consider all the parameters of different glycemic status of diabetes, new diabetes, pre-diabetes, or even normoglycemia, all such patients, this is something taken from the Paradigm Heart Failure Study, they favor sacubitril valsartan combination over enalapril, and all these parameters, if you see there to the left of the odds ratio. So there is a 20% reduction in the risk of heart failure hospitalization in such patients irrespective of the glycemic status, which is significant. It also improves the clinical outcomes in patients with diabetes and HFrEF. If you see, compare the glycemic status with respect to cardiovascular death and heart failure hospitalization. All these, they favor sacubitril valsartan, and there is a 20% reduction in the risk of cardiovascular death and heart failure hospitalization vis-a-vis sacubitril valsartan compared to enalapril, and this is again irrespective of the glycemic status, very important. If you see in this particular bar diagram, it reduces the rates of 30-day all-cause and heart failure readmissions. So, as was seen in the paradigm heart failure study, in the 30-day all-cause readmission, sacubitril valsartan fared much better compared to enalapril. There was almost a 26% reduction in the 30-day all-cause readmission and almost a 38% reduction in a 30-day heart failure readmission. So you see a 26% reduction in the risk of readmission in 30 days in heart failure patients. Also shows similar survival benefits in the Indian subgroup of the heart failure, the HFrEF patients. 35.09% of Indian HFrEF patients had diabetes in the sub-analysis as it was seen, and there was a 22% reduction in the risk of first heart failure hospitalization in the HFrEF patients with the molecule combination as compared to enalapril. So Indian patients did equally well. It improves the quality of life in HFrEF irrespective of glycemic status. It has already been alluded to by Dr. Ripen Gupta, and in this particular Kansas City cardiomyopathy questionnaire, you see the glycemic status, all of them favored sacubitril valsartan and provided a 17% quality of life improvement vis-a-vis the other molecule enalapril, probability within 8 months compared to enalapril. So it enhances the glycemic control in patients with diabetes, though it is not an anti-diabetic molecule per se, ostensibly because of its effects on the endothelial dysfunction and reduction of oxidative stress. As you can see, it reduces the HbA1c level by about 0.16% with the use of this molecule with the patients of diabetes at 1 year, and 29, almost 30% reduction in the new use of insulin is seen in such patients. So what about combining SGLT2 inhibitors in HFrEF patients along with the ARNI? So the ACC 2021 consensus recommends using SGLT2 after using optimal HFrEF therapy in patients with diabetes as a comorbidity. So it's already there in recognized as one of the molecules to be used in conjunction with beta blockers, diuretics, MRAs and ARNIs. So once the diabetes has been diagnosed, you optimize the HFrEF therapy and administer SGLT2 inhibitor, and obviously in consultation with a diabetologist or an endocrinologist. It's used as an add-on therapy, and they are taken as part of therapy for HFrEF patients who are already receiving ARNI beta blockers, initiated as an add-on therapy after the preferred first-line therapy, which is ARNI. Additionally, the ACC 2021 consensus also recommends initiation and dosing of SGLT2 inhibitors with ARNI and evidence-based beta blocker with diuretic agent as required. But one has to keep a check on the GFR criteria. One can initiate either of the two recommended drugs, dapagliflozin or empagliflozin, but one should ensure that the eGFR is more than 30 in the case for DAPA and more than 20 in the case for EMPA. And novel therapy of SGLT2 inhibitor is now recommended as an add-on therapy. And if you see, for patients with HFrEF with or without diabetes, the use of SGLT2 inhibitor stands vindicated, and administration in conjunction with the background of the guideline-directed medical therapy for heart failure. So, with SGLT2 inhibitors showing promise in HFrEF patient, is there any evidence for use of SGLT2 and ARNI together? Let's see. So the combination of SGLT2 inhibitors and ARNI resulted in a better cardiovascular protective effect profile in both the DAPA-HF and EMPEROR-HF study, in which the pooled meta-analysis data indicated a lower occurrence of CV death or hospitalization for heart failure in patients taking both SGLT2 inhibitors and ARNI. Likewise, the combination of SGLT2 inhibitors and ARNI shows better clinical outcomes compared to conventional therapy in HFrEF patients. And if you see, all the parameters which were analyzed of cardiovascular death, hospitalization for heart failure, and hospitalization, admission for heart failure and all-cause mortality, it favored the comprehensive therapy with the combination, which halted or delayed the clinical progression in HFrEF patients compared to conventional therapy. So combination of ARNI, beta blocker, MRA and SGLT2 inhibitors can be used as a new therapeutic standard in HFrEF patients. So to summarize, Type 2 diabetes increases the risk of admission for heart failure by almost 5-fold. The ACC 2021 consensus recommends initiation of sacubitril valsartan as a first-line therapy in HFrEF patients. Initiating sacubitril valsartan results in the reduction in hospitalization rate in HFrEF patients irrespective of the glycemic status, and the combination of SGLT2 and ARNIs results in a better cardiovascular protective effect profile in HFrEF patients. So thank you very much for your patience. So, as we've gone through the 3 lectures which have given you wonderful insights into the therapy with sacubitril valsartan in the situation of heart failure, and conditions have been described as per the lectures that we have just listened to. The forum is open for discussion. I invite Dr. Ripen Gupta on the dais, and Dr. Chhabra is already here.
You already have a mic.
I'll just take this one.
We'd like to have one mic here.
Yes. I've already summarized the meeting, so questions if any would be addressed.
Yeah. So, what an excellent talk by all the 3 very distinguished speakers. And let me begin with asking Dr. Ripen. So, psychological risk factors must be integrated in the treatment of heart failure. What do you say, sir?
Yeah, definitely the scores take that into account. Questionnaire which this is a long questionnaire, but when we do it in studies, we only take those factors.
So, probably CBT better than antidepressants in the treatment of the psychological risk factors here. And, the Fantastic Four, which all 3 of you talked about, the sacubitril, valsartan, beta blockers, MRAs, and the SGLT2 inhibitors, irrespective of the patient, whether the patient is diabetic or not. So, newer perspectives and emerging evidence suggests that these are prognostic modifying risk drugs. So, how do you start? Do you start with what? RD first and beta blockers, or also go together and stepwise escalation as well?
Yeah. So, important thing is that we should have all the 4 molecules in. So, the concept is that if you cannot start all the 4 molecules, depending on the pulse rate or the blood pressure of the patient, let's say if the pulse rate is already low, then beta blockers cannot be initiated maybe as a first go. We can give them in a stepwise fashion. But the aim is that within 4 weeks, all the 4 molecules should be in on the patient. So that is very important. Sequence hardly matters. Though there is a rapid sequencing, they have recommended that we can give an SGLT2 inhibitor and a beta blocker in first go, add an ARNI once the patient stabilizes, and then can add an MRI to the patient. Or we can give an MRI first and give an ARNI later on. So this is one of the proposed mechanisms. But important thing is that we should start all the 4 molecules maybe in smaller dose rather than starting a higher dose of 1 molecule. So concept is all the 4 molecules in 4 weeks, that is within 1 month, and a smaller dose of the molecule can be given.
So, Dr. Ripen, you talked about the acute decompensated heart failure. You said you could start right from the first day. Aren't you worried about hypertension when you're also giving loop diuretics?
Yeah, so important thing to remember is that when we say of acute decompensated heart failure, we do not start when the patient is on inotropes. Once the patient is off inotropes, and the loop diuretics are on a decreasing trend, that is the time when we start the ARNI in this patient. Important thing to remember is that, and the tip is that we start with a very small dose. not many books we start with 1/4 of a tablet of 50 mg twice a day, so that the impact on blood pressure is low, and we decrease the dose of diuretics slightly more once we start RP, because if you give more diuretics and RP together, then you can have hypertension. Dr. Gagan also said that this is one of the reasons for rising of creatinine level in the hospital setting. So we are very careful about that. That we decrease the diuretics, add a small dose of RP, see the response, and if the patient is tolerating, then gradually over the next few weeks we will increase the dose of RP.
My next question, Dr. Ripen, would be regarding ivabradine. See, it's been known to reduce heart failure hospitalization as well, but would it act in atrial fibrillation? In heart failure, it would not. What do you say, sir?
So, important thing to remember is that ivabradine can in fact lead to more atrial fibrillation.
Right.
So we do not use it in atrial fibrillation, but it can be used as add-on therapy to beta blockers. Let's say you have given a small dose of beta blockers, patient has a PR interval which is 240. You don't want to give a more dose of beta blockers, then you can add a, but the heart rate is still on the higher side. So we need to target a heart rate around 60. So we can add ivabradine to these patients where we cannot escalate the dose of beta blocker because of certain reasons.
Right. So regarding imaging, so 3D TTE versus CMR, probably CMR is superior, has a better or a higher spatial resolution, and probably would identify scars and fibrosis early as compared to the 3D TTE. What do you say, sir?
Yeah, I agree with you that CMR is better, but then it is costly and not freely available. So I think echo scores over that, and most of the now newer echo machines can do a good tissue Doppler imaging, so it gives us quite a good amount of idea. So that is more practical for use, but for study CMR is better.
Right. And Dr. Pin, would you say, probably Circulation January 2022 talked about the CAC-CT screening in patients who are diabetic. Probably they need to get a CACT done to, probably intensify high dose statins. What do you say?
Yeah, you see, there is a dichotomy of opinion. Calcium scoring has been advocated more in US. All the studies done in US or guidelines from US, but Europeans are more conservative. I think we try to follow more of the European guidelines because we have to take into cost into consideration also and the availability of tools. So I'll be not using CACT that much in my clinical practice as I want to, because number one, cost is an important factor, limiting factor for me, and I think we need more studies because US is a more cost-intensive structure. India, we have to be more pragmatic.
In any case, all of them are on heavy dose statins.
Yeah, but still, if you want to,
So if your calcium scoring is more than 100, you probably need to give high intensity statins. So Dr. Chhabra, so you talked about ARNI delaying the progression of renal dysfunction. So how does it do? What's the mechanism of action?
So I briefly discussed the mechanism of action there. That is what I in my talk also said. That's basically the neprilysin inhibitor, which is playing a role as a starting point. We want to inhibit neprilysin because it is actually causing the degradation of the natriuretic peptides. And we all know natriuretic peptides are very important both for improving the cardiac function, decreasing the load on the heart, getting a good diuresis and natriuresis also. So that's why they are required. If you block an inhibitor, you block a neprilysin, then you are increasing the natriuretic peptide. That's one thing you are doing. Now, what is counterproductive here is that once you block neprilysin, you are also increasing bradykinin as well as angiotensin 2. Those are both which are not going to help us because they are creating a RAAS activation rather than RAAS inhibition. So to block that, we need a RAAS inhibitor. That's why we need an ARB here to block that. So simultaneously, if we use two molecules together, we are actually creating a pro-kidney and a pro-heart environment. That's how it works.
So, Dr. Chhabra, further to what you said, what about the GLP-1 agonists? They are known to cause, to reduce macroalbuminuria. Why I said was that probably, a CVOT involving 8 CVOTs involving 60,000 odd patients said that this indeed reduces macroalbuminuria and a robust benefit seen with this drug, particularly the semaglutide. What do you say, sir?
So there are studies coming up with this molecule, and there's a definite benefit seen, and we are trying this molecule. In fact, we're having a study in our own department, and we are trying to get a molecule to as low as a GFR of 20. Now, all problems here is lying with the GFR. You ask a cardiologist, if you ask me, my first line of treatment for a patient of heart failure may not be an army. I may be jumping a line here, but because you see, most of the patients already have a renal dysfunction. So we are very susceptible using MRAs, hyperkalemia sitting on our head most of the time. And you see most of the prescriptions coming with the ARP and a MRA together, you have a hyperkalemia instantly. And so that's why we prefer little, maybe SGLT2 first. I'm maybe going out of the guidelines here, but that's what practically has worked for me and worked for all the kidney patients also. Similarly, the semaglutide molecule you're talking about, sir, is a very good molecule, but the data on a kidney disease, advanced kidney disease is lacking. So we are getting that data, and hopefully in next 5 years, this will be the next upcoming thing. We will be using it more often as compared to what we are doing it right now. The main problem is that the GFR, you see, once the creatinine jumps below above 2, especially the elderly, in which most of our patients are, the GFR actually dropped below 30. And most of these studies are actually talking about GFR above 30. So we are practically in a soup before we start. And also, we must know all these molecules, SGLT2 as well as ARNI, will lead to a decline in GFR initially. Both SGLT2 as well as ARNI. So that also is very important to monitor.
Dr. Chhabra, please correct me if I am wrong. So, ACE and ARBs cause probably hyperkalemia, and SGLT2 inhibitors take care of hyperkalemia. What do you say?
So true, that's an important point here, and we can use them together. Also, there is some diuretic effect of SGLT2. So once you add SGLT2, you have to be very careful to try and reduce a diuretic also along with it. Because if you are already using a diaper in a high dose, and you add an SGLT2 on that, there is a possibility that the creatinine will go up. And next time you realize it's probably because SGLT2 is not probably because of SGLT2, is the additional diuretic effect that you have given. And probably you try and withdraw the diuretic, next time you see the creatinine goes back down.
No, not necessarily. Because if you give loop diuretics, probably increased hyperkalemia would occur as well. Okay, so now to Dr. Sengupta finally, sir. Much to learn. What you talked about. So how do SGLT2 inhibitors reduce heart failure? Multifactorial, but probably the greatest benefits would be the interstitial fluid space reduction as compared to the blood volume. Would you say that?
True, that's one of the very important mechanisms of action, and offloading of the fluid volume is significant.
And not compromising on the organ perfusion as well.
Also, as we have seen in the trials which have come through, it has huge beneficial effects on endothelial dysfunction also, and associated obviously by reducing the glucose load already, many of the beneficial cascades are also set up.
What about the improved myocardial energetics, direct cardioprotective effects beyond that of remodeling as well?
Absolutely. So that is why both these molecules, dapagliflozin and empagliflozin, have now been indicated for non-diabetic heart failure also.
Thank you, sir.
So thanks. I am Dr. Nograna. I have a simple question. A patient who is hypertensive and he is on ACE inhibitor, there are some side effects, and one of the most and dangerous side effect is the backache. Why it is causing, and what we should do if a patient is having a backache, then what is the next generation of drugs we should put on the patient?
I'm not aware of it being. I'm not aware. I mean, the house open for discussion. I mean, your opinion. I mean, I'm not aware of.
These are not studied. Maybe because also these patients must be there. So if you have a
You are speaking from experience or any kind of
No,
report?
sir, basically number of patients which I had put on ACE inhibitors, they come to me with
No, are you talking about ACE inhibitors or SGLT2 inhibitors?
ACE.
To my knowledge, I'm not aware of backache being a significant side effect of ACE inhibitors. I don't know.
Sir, any, sir, because you are the
Well, he's googling it.
No, it's not. I'm not googling it. I'm not a Google doctor, sir.
Dr. Ripen is Googling.
Okay.
We are not aware. It's open for discussion. If anybody else has seen or observed, Dr. Chauhan sir.
No, I am not.
Dr. Manish, Dr. P.K. Gupta sir.
We have not, Dr. Anna.
I mean, as a known side effect, incidentally, maybe you may be looking at other pathology.
See, I had patients with whom I have put them on ACE inhibitors, and they come with the backache, and that's the biggest problem. You try to find it out that what is the reason, and when you remove the drug, the backache goes. So my question is, because you are the three stalwarts, or three best doctors of from the very big institutions, and you must be knowing it. And what is this causing? I want to name the reason.
You see, number one, we have to see the. I have never seen a backache happening on a ACE inhibitor patient. Number one. So the question arises that I have never studied this side effect, never heard about this side effect. I think neither Dr. Gagan or Dr. Sengupta has. So I think we can have this discussion later on. Let us Google it and see research and do. And we can have a discussion.
No, on a jocular note, since you are a sexologist, I think they might be doing sex in the wrong position.
Sir. Just a minute. Dr. Sir, we had a wonderful discussion and you showed some wonderful slides. This sacubitril valsartan combination, I think, is the first combination which is actually showing mortality benefits.
Mortality benefit is maximum with beta blockers. It was something like 34% with beta blockers, something like 20% or with ACE inhibitors. And MRAs were around same as ACE inhibitors, SLD2 lower down. But RNE is more than ACE inhibitor and comparable to beta blockers. So if you take mortality benefit, then it is equivalent to beta blockers and better than ACE inhibitors. But advantage of RNE is that it is having double the mortality benefit as compared to ACE inhibitors.
Sir, my question is, if RNE has only equivalent benefits to beta blockers, then why do you use such costly molecules?
Dr. Chauhan, we can't hear you. We can't hear you.
So Dr. Chauhan has a very important question.
With the mic.
So Dr. Chauhan has a very important question that why should we give RNE and why should we give beta blockers when they are having similar benefit? Beta blockers are cheaper, RNE is costly. You see, what you have to understand is that heart failure carries a very high mortality. Even despite the best medication, half the patients will die in 5 years' time. So we need to give all the molecules which have mortality benefit, and what we have seen is that the mortality benefit is independent of each another. It's not like if you give beta blockers, the mortality benefit is there. If you give RNA, the mortality benefit gets reduced or gets mitigated. So as I showed in one of my slides, that if you add a RNA or an ACE inhibitor to beta blocker, the benefit is more. But benefits clearly is more when you give an RNA and beta blocker and MRA and SLG2 inhibitor. So we are dealing with a very serious problem where we want to increase the longevity of the patient and also improve quality of life. So if you give all the 4 molecules, the benefit is maximum. We lead to something like close to 60-65% reduction in mortality. But if you give them alone, then the mortality reduction is close to 34% for beta blockers, something like 29-30% for RNE, and 10% for MRE.
Can I add to this, Dr. Ripen and Dr. Chauhan? So 2 disease-modifying drugs in low doses are better than to give a single disease-modifying drug in high dose.
Sir, so today if I have a type 2 diabetes, about 50 years old, with an injection fraction of 20%, and I put him off all the 5 drugs. I put him on RNE, put him on beta blockers, put him on diuretics, SGLT2 inhibitors, and MRSA. What is the kind of longevity I achieve, sir?
So, what you can understand is that it depends on the individual patient to patient, but we can expect a 64% reduction in mortality of this patient. which is a huge number. So that we reduce the mortality. If the longevity was, let's say, 5 years, we can increase, like one of the slides have shown that average lifespan increase by around 9 years if we are giving RNA to our patient. So if we give this molecule, we definitely increase the longevity of this patient. And important thing is the diuretics we do not, we give for only symptomatic relief. The 4 molecules which we say MRA, SSG2 inhibitors, ACRBs and the beta blocker, they are given for mortality benefit. Clearly, once we are giving SSG2 inhibitor, we tend to stop the diuretics or decrease them to the minimum possible dose so that the patient can tolerate more of RNA. And you will see that once we are giving RNA, patients are able to take a higher dose of RNA as the LP improves. So let's say I start with a 25 BID dose. In a few weeks, I will be increasing to 50 BID and maybe going up to 100 BID. Once the patient's EF improves, his BP improves, we can take more of RNA. So that's what I'm saying.
Sir, I have a question sir here. Higher the dose of RNA you give, higher is the mortality benefit?
Yeah, definitely. You see, we have to go to guideline-directed medical therapy to achieve the percentage of benefit we are seeing in the trials. But as the data is very clear, we start with small dose, start with all the 4 molecules, rather than aiming for a higher dose of RNA.
Okay. So, now to Dr. Gagan Chhabra sir, there are 2 basic things that we are looking at. One is improved ejection fraction. Second thing is improved eGFR. With the RNA that we have in place today, especially in type 2 diabetics, using early RNA, does it improve eGFR prognosis, sir?
So actually the word is not improving of the AGFR, it's progressing declining of the GFR which is being prevented. So improvement may or may not occur, but the decline slows down. That's the important point. And this is the first thing I want to answer for your question.
All type 2 diabetics
Yeah. So,
at the age of 40 years, they must get RNA, sir, according to you?
No. It's not about RNA. RNA has been validated only with the patients of low ejection fraction here or a heart failure patient. We're not discussing a plain type 2 diabetes or diabetic kidney disease here. So there is not a recommendation for a plain type 2 diabetes with a diabetic kidney disease to use an RNA right now. The drug of choice still remains the ARBs and the ACE with the addition of SGLT2 now coming up, because these all molecules lead to a decrease in albuminuria, which was rightly pointed out earlier. And the decrease in albuminuria is what is causing the progression decline to prevent that.
What is
That's the main aim.
Sir, what is the stage in type 2 diabetes where you decide that ARB or ACE inhibitor should be replaced by RNA?
So we do not do that. This is not a recommendation for type 2 diabetes for RNA to use as a first line drug or even as a drug for correction of this thing. We use plain ARBs or ACE inhibitors for that. RNA is not for that.
It's only for heart failure.
It's only if the ejection fraction is low, decreasing less than 40%. Plus now studies are coming with preserved ejection fraction also. I don't want to go into that details. That details are separate. It's not in the clinical guidelines. But yes, with a low ejection fraction, less than 40%, if you have a type 2 diabetic patient, and you see that the eGFR is greater than 30, you can go directly with RNA or you can go with the ARB and then switch to RNA, but not with the ACE. Otherwise with ACE you have to give a washout period of 36 hours minimum. So if you are on an ACE, give a washout period of 36 hours, then use an RNA. If you are on an ARB, you can switch to RNA. If you want to use the direct RNA, yes, you can use direct RNA, but the low ejection fraction patient, heart failure patients with a diabetic kidney disease or a non-diabetic kidney disease.
Sir, in a patient of type 2 diabetes, when you decide to use RNA and SGLT2 inhibitors, what is the most important parameter you look at?
So now this is very interesting. With the coming of the DAPA trial, we actually have this something very interesting here, that DAPA has allowed us to use SGLT2 inhibitors in GFR as low as 25. Now, which is not the case with ACRBs. So we stuck with 30. The figures are very important to patients. They are all knowledgeable right now. So they will stuck कि आपने कैसे use कर लिया with a GFR less than 30. So now SGLT2 becomes more important. That's what I was trying to tell earlier also. Because if eGFR is even less than 30, more than 25, you can still go with SGLT2 first. And then you see if the eGFR improves due to some reason the other things. The eGFR improves more than 30, then you can go and add an ARB. But if it is more than 30, then as per the guidelines, still the drug of choice to start first is the ARBs. if there is a proteinuria. Now we are talking about two different things here. This heart failure is totally gone. What I am trying to discuss now is only a diabetic kidney disease in which the main aim is to decrease the proteinuria. And the first aim is to decrease the blood pressure also as per guidelines. So if the blood pressure is high, proteinuria is there, then you definitely are looking at ARB first. But if the blood pressure is okay, you are only going to start a patient with a mild proteinuria, and who's a diabetic, it comes to you with an albuminuria of say 200 or an albuminuria of 500, his blood pressure is 110/70. Now the first choice earlier would have been a different molecule of a diabetic kidney disease, but now is going to be an SGLT2. That's what it is.
Dr. Gagan, Chhabra, you practice only in Max or you have your own clinic?
I have a small clinic, sir. I stay in J Block, CR Park.
So where is that small clinic and what is the address?
I'm allowed to share the address on this.
Yeah, you are.
So I stay at J Block, sir, 1870. J Block 1870, Chitranjan Park.
Near Dr. Arvind Gaur.
It was wonderful listening to you, Dr. Chhabra, as it has been to Dr. Ripen Gupta always, and our own darling Dr. S Sengupta. Over to others.
Sir, can I ask a small question?
After big questions are your side. Your side.
After listening to all this very high talk of SGLT2, after listening to very high talk of army and all the newer techniques of treating congestive cardiac failure, what is the role of diuretics? Dr. Ripen has already said it is for the initial stages and for controlling little bit. Where it stands, we use these drugs very often these days.
Sir, we have to remember that once we have a heart failure patient, we are giving medicines for two purposes. One is for symptomatic control of the symptom of the patient, improve the symptom, and second is for improving the lifespan of the patient. So the diuretics are only to improve the symptoms. So they are used in when the patient is having a decompensation or he is having a lot of breathlessness, then we'll give a diuretic. Once the patient stabilizes, we'll substitute the patient with a RNE and a SGLT2 inhibitor. So SGLT2 inhibitor also have a partial diuretic action. They can be given now in non-diabetic patients in heart failure also. So my aim in this patient is that decrease the dose of diuretic, gradually stop them and put them on a high dose of RNE and SGLT2 inhibitors, which will improve the quality of life and also longevity of the patient. So diuretics are to, otherwise you should decrease the dose.
Sir, we often get patients who come to us with breathlessness, often without having edema on the feet, without having enlargement of the liver and classical symptoms of CHF. Today only I got a patient, a lady, who was operated about 10 years back for a valve replacement and was complaining of breathlessness. Her ECG was normal. In such patients, normally what we do is to give a diuretic and that gives relief in the breathlessness.
Yeah.
So where to put these newer drugs in such patients?
Yeah. So sir, first thing is you give diuretics, call them after 7 days. By the time the patient symptom has improved, now you must get an echo done, see the ejection fraction. If the EF is on the lower side, then we can add these RNE. You see, it is same like using an NAC. So we are very well versed in using ranitidine in our clinical practice. Same way we can use RNA in our patients. So there is a stage when you start RNA and if possible put an SGLT2 inhibitor and increase the dose of diuretics in the next 1 or 2 visits. So when the patient is breathless, we should give diuretics to symptom. We cannot give RNA at that point of time. But once the patient stabilizes in 7 or 10 days time, then we put an RNA.
Thank you, doctor. That was very nice.
So, what is the role of hydrolysine and nitrate still in?
You see, basically, Dr. Gagan is with me and he can also talk on this. But if the patient, for some reason, we cannot give an ACE ARB, his creatinine is jumped up and he's still having a heart failure patient, then we use that in those subgroup of patients. So the trials have shown it to be poor man's ACE. So it is given where ACE ARB or RNA cannot be given. So we use as a substitute. but clearly when the creatinine is on the higher side, and somehow potassium is very high, creatinine is high, you cannot get RNA or ACE inhibitors in this subgroup patients. That is the time when we use this combination.
Sir, it was an excellent, lectures today. Everybody spoke very well. Dr. Gagan was excellent. Dr. Ripen, Dr. Sengupta. My thanks to you for giving us so much of good information.
Dr. Mangla sir, what?
Yes, our senior and our guru, Dr. Mangla sir, has a question, and I am so grateful to him. Not because he is asking a question, but because he is asking a question without alcohol.
Very small. No petrol. If a patient has ejection fraction of say 10-15%, and is presented to the hospital for the first time with dyspnea, and he has a global hypokinesia. This patient, like he has heart failure, can we start beta blockers? Small dose in this patient, or should we wait?
Sir, first we have to see the clinical status of the patient. If he is NOH class 4, I will first try to give a bit of diuretics to stabilize him. And once
he is already on diuretic, we started RNA on him.
Yeah.
I was just saying to control his heart rate, should we give ivabradine or we can start with a small dose of diuretic?
Yeah, so this is a very, very good question. So I think what I usually do is give a very small dose of beta blockers and gradually increase the dose of beta and put an ivabradine along with that. Because what happens is that if you give a higher dose of beta blocker, he will not tolerate. So give a small dose of beta blocker, but that will not control the heart rate completely. Add an ivabradine, and in the next 2-3 weeks, go on increasing the dose of beta blocker gradually and decrease the dose of ivabradine.
And what is the high dose of diuretics you say? It is 20 classic 20 BD is a higher dose along with RNA.
So it is not like higher dose. Basically, we should try to decrease the dose. Let's say patient was on 40 mg of furosemide. And once you start RNA, I will make it 20 mg and try to see if the symptoms also does not worsen, and I can give the RNA to this patient. So I try to reduce the dose of diuretic, whatever the patient was taking.
Second is that, in this patient, since he has an ejection fraction of 10-15%, when should you consider AICD in this patient?
Sir, ideally, whenever a patient comes to us first, we have to rule out a blockage in the heart arteries.
Yeah, agreed.
So if it is ruled out or corrected, then we should at least wait for 2 months to 3 months before we get an ICD to this patient.
Even if he has a global hypokinesia,
Sir,
he should undergo coronary angiography.
venous acceleration has to be ruled out. So if he has a triple vessel disease and it is a hypertensive myocardium, so if we revasc this patient, he will improve.
You see, this patient also showed DVT. And we did a CT pulmonary angio on this patient. That was all right.
Yes.
But post angio, he had a very severe rigor, probably a reaction to the contrast agent. So how safe is the angiography in this patient?
Sir, if it was a definite contrast related this thing,
It happened immediately after that and responded to alcoholin.
so then I will wait for the angio, sir. But angio can still be done in this patient using a limited contrast, because the contrast we use for pulmonary angio is something 120 ml or something. We can do an angio on 10 ml contrast. So that is not a big issue. We give an F beforehand and do an angio in this patient.
And patients like these patients are on RNA and MRAs, how frequently is potassium be tested? Because our patients are not very good at doing investigation.
So, sir, regarding potassium testing, the patient on OPD follow-up, if it's going stable, has a dose increase or decrease, especially of ACE or ARP, should be checked after 1 to 2 weeks, the levels of potassium.
And how frequently?
The 1 to 2 weeks after it remains stable, and you don't change the dose, you keep it checking, not regularly 1 to 2 weeks is not required. Maybe after next follow-up, 2 months or whatever your next follow-up. But if you have increased or decreased the dose, especially of a diuretic, the ACE-ARB or a RNA, then you should definitely check this. Secondly, the patient of heart failure needs more frequent monitoring every 2 weeks, because one of those parameters are very important. The fluid status changes, and as the fluid status changes, the other parameters start changing along with that. So you need to check more frequently. In hospitalized patients,
it will depend upon how stable the kidney function is, then you can check frequently according to that. Maybe alternative.
Yeah, if this patient is maintaining blood pressure and has a good urine output, when should MRAs be started?
So, RAAS is not a contraindication that we can start all the four therapies. And ejection fraction is not. I have patients where EF is 35 and BP is 90 or 80 systolic, and patients like yours with the BP of 110, 120. So that is not, if his urine is stable and his potassium is okay, we can start MRA in the same setting only, in the hospital setting only.
Thank you.
So thank you very much. It's been a wonderful evening. And can you
this role of digoxin at present scenario?
Digoxin role has become very little. Only atrial fibrillation patients where we want to control the rate, we can still give that. Sometimes when I have nothing left on the table and patient is still symptomatic, I still give digoxin. But if you look at the evidence is very weak for digoxin as of now.
Age factor taking into consideration.
So, but as I told you, we try first these four molecules. We cannot give them. We have nothing to offer to the patient. Then we can add atrial fibrillation where the heart rate is very fast, beating on the lower side.
I think rest of the conversation can be carried over. Thank you so very much.